My name is Florence Nightingale. I was born in the year 1820.
This BBC education video tells how in the Crimean War 150 years ago, Florence Nightingale revolutionised the way we control infection.
Whatever we had imagined, this was worse. The first thing to hit you was the smell.
She found conditions in the army hospitals were appalling. Patients were dying of cross-infection. She learned from it separating patients according to their illness, spacing their beds, and enforcing strict hygiene. In just 6 months, she managed to reduce the death rate significantly.
It might seem strange talking about the Crimea War in the context of COVID, particularly with the focus being on PPE and testing. But the truth is, even with protective equipment and an increase in testing, coronavirus is still spreading around hospitals.
Data confirmed to Newsnight by PHE suggests up to 20% of people have caught the virus while in hospital. By definition, people who were kept in hospital during the pandemic for non-COVID illnesses were likely to be very sick, so vulnerable in becoming seriously unwell from COVID.
So how might COVID have wreaked havoc in what should have been non-COVID wards? Newsnight has been sent data that drill down into how COVID spread widely across one West Midlands hospital ward treating neurology patients in March. It's important to stress that a great deal has been learnt since.
The ward had 22 beds and 3 more in individual rooms. It was a neurology ward where many patients were already seriously unwell and where many were undergoing medical procedures likely to lead to the patient coughing and potentially increased risk of COVID spreading. This animation tracks from the 12th of March to the 25th of April, 21 patients who would test positive for COVID at some point in their admission. A yellow circle means the patient has been tested for COVID-19 and red means they've tested positive. It becomes apparent that, with bed occupancy high, patients are being moved from one bed to another very frequently. Patient E had been in another ward elsewhere in the hospital. On the 29th of March, patient E, who was displaying symptoms of COVID, was moved into a side room and tested. The next day, patient E was moved back into their previous ward. The following day, they were transferred first to bed 1 on Bay 1 and then to bed 1 on Bay 4. Then on 1st of April, they're transferred to a side room and later that day, their test comes back. It's positive. In the space of 4 days, someone suspected to have had COVID occupied 5 different hospital beds, coming into close contact with so many other patients.
If we had more single rooms, if we'd not stripped out the numbers of beds compared with other developed countries, if we had more rehabilitation facilities so the patients who don't need to be in hospital could be relocated safely somewhere else, the need to move patients would be greatly reduced. And we are really, in a number of aspects of our response to COVID, reaping the problems that we've created for ourselves by building hospitals which were too small, that had insufficient beds, insufficient space and insufficient areas for staff to safely work in. And that's going to take quite a lot of putting right.
Of course, there are many times it could never be possible for staff working in a hospital to socially distance from each other. But there are times when it could be possible, particularly if hospital design allowed it. There's an increasing realisation that many infections are passing between staff.
Last month, the Health Service Journal reported NHS England's National Director for Acute Care, Keith Willett, as saying,
"The infection risks from staff to patients or patients to staff seems very low, but the risks to staff of COVID-19 infection within hospitals is much, much, much higher between staff and staff."
And NHS England National Clinical Director for Trauma, Dr Chris Moran, said,
"We know when directly managing patients that social distancing is impossible. That's what PPE is for, to protect both sides of the equation. But I think in the staff-only areas we could do quite a lot better in some of the places that I've visited."
Transmission between members of staff when they're actually relaxing, when they go to areas where you would think there are a lower risk of transmission, into parts of the hospital which are non-COVID parts. That's increasingly, I think, being recognised as being an area which we need to focus on.
Given that hospital buildings are hard to change easily, going into winter, people warn that it will mean the way we use the NHS may have to change.
The NHS normally has around 100,000 general acute beds, which are used to treat hospital patients. Effectively, that's going to be reduced. A big chunk of that is going to be taken out by the kind of measures that have to be taken to control the spread of the virus, whether that's in terms of people working more slowly because they have to put on and off extensive protective equipment between patients, or whether that's because wards have to be reconfigured to split coronavirus patients from non-coronavirus patients.
This was how I'd imagined it. Clean and hygienic and everything in its place.
The challenge for the NHS today is huge. Hygiene and cleanliness alone are no longer enough. Experts are keen to stress that the risk of not going to hospital for some people who are acutely unwell outweighs the risk of being infected with the coronavirus. But for people with all conditions, we're likely to see big changes ahead.